Hello, everyone. My name is Iman Plaja Reddick. We are pleased that you could all join us for this week's lecture in Volume 8 of our KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. We would like to thank our 2023 sponsors for their generous financial support of this series. Additionally, we are grateful to our International Neuropsychology Society colleagues for their sponsorship and wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It will be held in New York City from February 14th through 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get free access, first access to new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Crystal Fullen for today's lecture titled Cognitive Rehabilitation in Neuropsychology. Dr. Fullen is a clinical neuropsychologist serving the departments of psychiatry, neurology, and trauma surgery at the University of Arkansas for Medical Sciences. She graduated from Our Lady of the Lake University with a doctoral degree in psychology and completed her clinical internship at the South Texas VA in clinical neuropsychology. Her fellowship training was completed at UAMS, where she focused on furthering specialization in neuropsychological assessment and treatment of acquired brain injuries and rehabilitation. To that end, she has developed and directs a multi-tiered cognitive rehabilitation program at the hospital to foster interdisciplinary inpatient and outpatient rehabilitation of cognitive dysfunction, primarily in the TBI population. Her rehabilitation program also includes behavioral management of post-injury psychiatric symptoms, family psychoeducation to improve recovery outcomes, and brief psychotherapy to improve adjustment to injury outcomes for individuals. The program further serves patients with other injuries or neurological diseases, including stroke, anoxia, tumor, epilepsy, and multiple sclerosis. Her work with the MS population includes multidisciplinary collaboration and assessment, rehabilitation, psychoeducation, and brief solution-focused therapy for MS patients, as well as developing updated evidence-based manualized treatment for rehab medicine. Dr. Fullen's research has focused on rehabilitation, epilepsy, brain injury, and performance validity measures. She is also well-versed in the tenets of program development and evaluation in psychology. And in 2022, she developed an inpatient neuropsychology service to expand assessment and intervention in the UAMS Level 1 Trauma Center. Well, Dr. Fullen, you have our full attention. We are so excited to learn from you today.
All right, guys, as mentioned, my name is Crystal. I'm one of the clinical neuropsychologists at UAMS. Within my role at UAMS, I provide both assessment and intervention services on the inpatient and outpatient sides. And today I'm going to share with you more about the intervention side of my work, specifically cognitive rehabilitation and what that looks like in neuropsychology. Okay, I'm going to try to move my slide. Excuse the tech delay. I cannot see the move slide button. There we go. All right, so a brief agenda. What I'd like to do today is really start with what cognitive rehabilitation is, and then discuss a brief history, which I think is pretty interesting, and then move to the types of cognitive rehabilitation, including a neuropsychological approach to cog rehab. and then share with you some updated practice recommendations for anyone who is providing rehabilitation, look through some of the research trends, and then share some of my favorite resources. That's probably an hour in and of itself, so I'm just going to give you a sampling of my favorite resources, and then hopefully, if time allows, look at a case presentation. All right, so there isn't really an agreed upon definition of cognitive rehabilitation to date. And while there's no agreed upon definition for what constitutes cog rehab, I'm going to break down what the process entails throughout the presentation. What we do know is that cog rehab has been around for a long time, and that over the years, it's been referred to by many different names. And some of these you probably will be pretty familiar with. So things like errorless learning, cognitive training, neuropsychological rehabilitation, and neurorehabilitation, all kind of describing the same thing, the process of rehabilitating cognition. But the name cognitive rehabilitation actually comes from the Latin cognitus and rehabilitatus, which directly translates to restore what is known. So let's take a look at that brief history. So I always think it's interesting when there's something that we refer to pretty often and something that we're still learning a lot about that has such deep roots, and cognitive rehabilitation is one of those things because it's been around for over a century. One of the first official writings of a type of therapy that was designed to target cognitive domains was actually published in 1896. By a guy named Professor Loisette, and he wrote a book called Assimilative Memory, or How to Attend and Never Forget. And it's kind of cool because you can check out and buy the book on Amazon. And the book really includes chapters that are focused on strategies to improve both attention and memory, which, as we know, are very strongly connected. Now, the memory strategies that he talks about is really related to assimilative strategies, which is an internal memory strategy that is well known, called association, so associative learning. So after Professor Loisette's book, there have been multiple reports throughout the history of rehabilitation hospitals. These popped up most often after the World Wars and were really aimed at improving the lives of wounded soldiers. And even in these sort of older writings, we'll see that these efforts were aimed at real world application. In fact, in Germany, they actually named some of the hospitals schools for soldiers. And what they would do is they would do testing that involved work samples. So how to measure concrete skills to help people not necessarily focus on improving their attention or improving their memory after neurological injury, but how to improve their ability with concrete skills in order to put them back in the workforce. Despite some of the earlier writings that you can find on Amazon, Luria was the person who was credited with the first formal writing on cognitive rehabilitation. Part of that treatment included things like assessing for strengths, assessing for weaknesses, and then using compensatory strategies to focus on those weaknesses. Post-World War II, the British father of neuropsychology, Oliver Zangwill, also made a big splash in the research with his aphasia studies. And even in those writings included a focus on neuropsychological rehabilitation. And interestingly, also spoke about not necessarily just retraining aphasia. Language disorders actually historically do really well with retraining and rehabilitation, but there are sometimes difficult cases. And Zangwill discussed these and spoke not only about retraining, but shifting to a substitution model for language difficulties, whether it be receptive language difficulties or expressive language difficulties, if someone wasn't responding to retraining. And then despite being around the turn of the century at that time, there was definitely a little bit of a slower adoption of cognitive rehabilitation in the United States. This was mainly due to people trying to figure out, who are going to lead these efforts, and some funding limitations as well. But by the 80s and 90s, we saw a big increase in the research and in treatment availability for patients with neurological insults in cog rehab. And this is probably because of the development of cognitive psychology around the same time. So I read all about the history of cognitive rehabilitation in an article by Parente and Stapleton called The History and Systems of Cognitive Rehabilitation, if you guys want to read more. And then I also want to draw your attention to the left of the screen. This was in an article by Gomez et al. In 2019, and you can actually see the growth of the research of cognitive rehabilitation in the literature, and really some of those spikes in more recent years. All right, so thinking about all of that, what does cognitive rehabilitation look like today? And how can we explain the process of cog rehab and the purpose of cog rehab to our patients? Well, cognitive rehabilitation is a type of therapy, but instead of it being a traditional type of therapy, cog rehab focuses on cognitive domains as treatment targets. So everything from attention through to visual spatial skills. The goals of cognitive rehabilitation are typically to improve cognitive abilities, but not to restore cognitive abilities to baseline functioning, just to improve them, and to improve them to the degree that we can decrease barriers to recovery after any neurological insult. Or a better way to think about this might be to target anyone who has any cognitive decline. And then the outcome of cognitive rehabilitation should always be to gain functional independence. Now, I will say that when I was first exposed to cog rehab, I was taught that the outcome of cog rehab was really in quantitative gains following pre-post-treatment cognitive testing. But the field of rehabilitation medicine as a whole and the neuropsychological rehabilitation is really moving to a more ecological focus. And as such, we want to lean into how well people are able to do in their everyday lives and not in how well they're able to do on objective testing. Specifically, cognitive rehabilitation needs to be generalizable to everyday life. Basically, retraining just memory or just attention alone is not going to improve independent living skills. There are other things that go into that as well. Also, thinking about cog rehab in neuropsychology, I like to emphasize that although we talk about treatment targets as cognitive domains, I also like to encourage people to remember that those domains are interrelated with one another and also related to other factors, including psychological factors like mood, and then physical factors like pain and poor sleep, which can impact cognition. So some additional things tend to become treatment targets as well. Okay, so there are a lot of different delivery methods for cognitive rehabilitation. The most common is individual rehabilitation. But you can also deliver cognitive rehabilitation to families and in group settings. Actually quite like group rehabilitation. It does offer additional levels of social support. It helps increase motivation of the participants and tends to be cost effective. So if you are sort of piloting a new model and there's only one of you and lots of patients who could benefit from your rehabilitation program, creating a delivery method that can be used in a group can be really helpful. With families and groups, it might seem like skill generation isn't as possible as it is with individuals, but real world applications can happen when people practice together just as easily as when you're using compensatory strategies and trying to apply that to everyday life. So there's definitely lots of opportunities. In addition, when you're working with more than just one person at a time, people tend to have, different perspectives, and that can really help increase executive awareness. So there are lots of places where people do cog rehab. And just to highlight a couple on your screen, ones that neuropsychology are usually involved in would be inpatient rehabilitation settings, outpatient settings, and then in community reintegration facilities, which I'll describe in a little bit more detail in the slides to come. Okay, So let's talk about some of the types of cognitive rehabilitation that we have today. So we have restorative rehabilitation, compensatory rehabilitation, and metacognitive rehabilitation. And despite some of the differences of these three varieties of cog rehab, all of them will share an emphasis in psychoeducation and then in improving quality of life for the patient. Okay, so restorative rehabilitation sounds like it is, all of these sound like they are, is really focused on restoring cognitive abilities and functioning. And the methods tend to lie in retraining through repeated practice exercises. These can be achieved by multiple methods, paper and pencil format, all the way through to virtual reality platforms. And many programs are computer-based, and some can be similar to some of the popular brain apps that are used. And so at times, restorative rehabilitation can result in improved ability at the engineered task and not have as much generalizability to everyday life. Now, although restorative rehabilitation has in the past been viewed with some skepticism, I don't want to confuse it with VR or technological approaches, because you can use VR or technological approaches with any type of rehabilitation. Restorative rehabilitation is simply more commonly achieved with computer-based practice exercises. This is a type of rehabilitation that's primarily geared to an individual and is not well suited for groups. So, I remember back in the day when people saw this picture, they'd be like, wow, now so many people have some of these things in their own homes. But what you see on your screen is the Razer Hydra and an Oculus Rift. This is a program that is used to train prospective memory, typically focusing on taking medications, appointments, and so on. And it's usually achieved through retraining and errorless learning strategies. So now we'll move to compensatory rehabilitation. Compensatory rehabilitation, definitely not as flashy as restorative rehabilitation, but has been consistently more effective in research studies. So with compensatory rehabilitation, what we do is we use well-established compensatory strategies to support deficits in any cognitive domain. For a more ecologically valid perspective, we can also develop patient-specific compensatory strategies to overcome the results of cognitive deficits. For example, like a patient example, if you have a patient, let's say, who has memory problems and works from home, uses a headset, and takes her dogs outside, and then can't hear that her dogs are barking at the door to let them back in, you might work together to come up with a strategy that could include taking a wristband, a colorful wristband, and putting that on the doorknob that she uses to let her dogs outside. And every time she lets her dogs outside, puts the colorful wristband on her wrist, goes back to work, and then sees and is visually cued that her dogs are still outside. So she can go back to the door, let the dogs inside, and then put that colorful wristband on the doorknob. This is actually an example that I came up with a patient with, came up together with to help. She had great visual attention, great visual memory. She was a visual learner, but struggled with other aspects of memory and attention, and this worked really well for her. So a great example of an ecologically valid compensatory strategy to help with a problem that her cognitive deficits were causing in her day-to-day life. Compensatory rehabilitation, as opposed to restorative rehabilitation, is actually more widely used in group formats and works well in group formats. The picture you see on your screen is known as the method of Loki, and it can be used to help someone recall typically popular recipe, like a famous family recipe, but also grocery list items. Here we sort of use an exaggerated visual picture of those grocery items or recipe items, and we try to remember them in a comical way in a familiar location throughout the layout of a familiar place, like someone's home. It's actually a little bit of a complicated strategy, but for some reason it works really well and people really like it. You'll also see pictured on your screen a study from an expert panel of clinicians and researchers who reviewed evidence published since 2014 and developed updated recommendations for intervention specifically for post-TBI and for memory impairment. And their results included that the primary strategy for severe memory impairment in COG rehab should always be compensatory in nature. Okay, so metacognitive rehabilitation is a little bit new to the scene, and again, sounds like it is. Here, the focus of the rehab is in improving awareness and understanding of both cognitive strengths and then areas of impairment. Ideally, what happens is the patient learns to troubleshoot compensatory strategies and anticipate when they'll be needed. And how we go about this is we do things like lots of self-monitoring exercises, self-reflection exercises, psychoeducation about cognition, and then typical problem-solving therapy. All of those things are used. Now, the research for metacognitive rehabilitation is limited, but that's also expected because it's newer. But it's growing, and studies are showing that people are having improved executive functioning, improved ability to self-monitor, and then improved ability to make corrections or basically shift when needed, when a problem is arising. And although you can use metacognitive rehabilitation in individual and group settings, there are a couple of limitations in groups, just because you're doing a lot of self-reflection. But you can always correct that by making sure you take time to do group reflections after small group activities so people can get some really live feedback about how they did, how they implemented a strategy, maybe what went wrong, and what they might consider moving forward the next time. So there are ways to kind of correct that, although it's a little bit more challenging. So although this community reintegration is not a type of rehabilitation, it's more a model, I wanted to share it. And the reason I wanted to share it is because it's probably the gold standard in rehabilitation medicine. The emphasis in this model is in return to the community using in vivo retraining and compensation. For example, someone might be learning how to pay attention using compensatory strategies, or in community reintegration settings where people are all staying in a home and their kitchens and bathrooms and different rooms set up for different activities. They can actually use attention strategies live while doing a task that requires divided attention, like cooking, with their rehabilitation specialist right there to help them and to guide them through the process. So community reintegration involves a team approach and includes goal setting throughout the program to ensure that people are really focusing on improving patient independence to the highest degree that is safely possible. There are loads of team meetings that happen with the patient, as well as family meetings with the patient's caregivers, partners, family members, and so on, so that we can make sure we're meeting goals and that everybody is on board with the same goals and that we're adjusting goals as needed. And this can really help when people leave the community reintegration setting and go home, so that there can be that continuity of what was helpful, what wasn't helpful, and what adjustments were made. So there is a large multidisciplinary team involved in community reintegration models and settings. And that includes everybody from neuropsychology to PM&R, all of our therapy teams, PT, OT, speech, family therapy, and more. Multiple additional services are typically used in community reintegration models. Services like housing assistance, recreational programs, day programs, transportation assistance, and then also just collaborating with local agencies to simulate work environments. So for example, in one of the community reintegration programs I worked at, we would take everybody to volunteer at the food bank to really simulate a work environment, how to employ safety strategies, how to use skills for distress intolerance, how to use your memory strategies, your attention strategies that you're learning. And even for other providers like PT, for example, different environments like this would help them to reinforce how to balance and walk on uneven surfaces. So real world application with live rehab happening all the time. Okay, so now for the good stuff. So neuropsychological approach to cog rehab. There are multiple books, multiple articles detailing what a neuropsychological approach to rehabilitation is. And many of them will refer to the inclusion of not only cognitive domains as those rehab targets, but then also emotional functioning as well. On the top of your screen, you'll see a new model named Rehab, which focuses on all of the above, with additional emphasis in those skills that make people successful when returning to the community, such as social skill training and communication strategies. So the approach Rehab, like many others, also uses a bottom-up delivery method. So really starting with the most simple tasks that we can, and then increasing those tasks in difficulty. So the neuropsychological approach to cog rehab also includes using our cognitive data to determine good fit for rehabilitation. For example, someone with global cognitive impairment might require focused rehabilitation from those therapy teams, PT, OT, and speech to regain independence in ADLs. Someone with significant memory and executive functioning deficits might struggle in a neuropsychological rehab program to recall information and organize information from rehab in a way that helps to improve their daily functioning. But someone with executive skills who has poor memory could use the structure from those executive skills and routine to inform the use of something like external memory aids. And vice versa, if you have someone with some memory ability, but poor executive functioning, they can recall strategies to use for things like problem solving. So we really want to make sure that we have treatment targets, but also anchors, something to anchor what we're going to compensate for. For example, let's say someone has difficulty with verbal memory. We can use a strength in visual memory to offset that deficit. So neuropsychological rehabilitation also includes the use of psychoeducation, just like the other models, throughout rehab. And that's really to inform understanding of how the brain works, how problems arise, and how to know when to use the strategies that they're learning to reduce the impact of those problems in their daily life. And we also use a really personalized goal-setting model when we're doing neuropsychological rehabilitation to ensure that we're targeting functional problems that the patients are reporting in their daily life as well. So in addition to rehabilitation fit, we can also use our test results to help determine those patient strengths and weaknesses. So that example before, using visual memory to offset deficits in verbal memory. Another example would be to use a picture to help you remember a password instead of a verbal clue for a password. There's some websites I've noticed are doing this now where they'll show you a picture to help remind you your password. Well, we've been doing that forever in cog rehab. So just a different way to get at more of a verbal memory problem. Finally, what we like to do in neuropsychological rehabilitation is ensure that we're also targeting all of the factors that decrease quality of life, limit involvement in daily activities, and impact cognition. So those are those secondary influences on cognition. So we target adjustment to injury as part of our treatment, and then any barriers to recovery. So things like pain, sleep, and fatigue are targeted with basic skill-based training, health psychology type interventions, brief interventions to improve the things that are going to impact cognition. So I always tell my interns and my fellows, everyone that I'm working with, you can be the best rehabilitation provider ever, and you can do wonders to improve someone's memory ability. But if they're also struggling with low mood, they can't sleep, and they're really fatigued all the time, no matter how good your strategies are, all of those things are going to cancel them out because they have such an impact on daily functioning, such an impact on cognition. Okay, so I wanted to show you guys this because I always think it's really interesting, and it's a question I often get asked about rehab. So if we consider the bottom-up approach that I mentioned earlier in the neuropsychological approach to cog rehab, this is something that we would typically follow. So if needed, if you have a patient who's coming in for rehab and they have something like anosognosia present, that's going to be your sort of basic skill, basic ability that you need to sort of engage in treatment, this knowledge that something is wrong and you need to do something about it. So we always start with something like rehabbing awareness if a deficit in awareness is present. And then what we do is we work upward in this sort of triangle to make sure that we're targeting everything that could be a problem as we go. When a certain area is intact, we would skip that area and then move to the next. So for example, if someone had communication difficulties or if someone had no communication difficulties, no problems with awareness, we would start with introducing attention, how it works, how things can go wrong, what external things impact attention, how to notice attention problems, and then how to target those attention problems with compensatory strategies. So although not expressly said before, neuropsychological rehab focuses on compensatory rehabilitation and includes some metacognitive strategies as well. Restorative techniques are only used really early after injury and typically work best on inpatient units and typically work best after stroke. And that's kind of what the research tells us. I thought of something, I can't remember what it is. Hopefully it'll come back to me. This is what it is. So a lot of rehab programs you'll find will have a combination of the different types of rehab in it. Some programs will be exclusively restorative, exclusively compensatory, but I think some of the really robust programs have more than one type of rehabilitation that is used to help target those cognitive domains and then other factors that impact cognition. Okay. Speaking of factors that impact cognition, for many people with new injuries, such as TBI, such as stroke, adjustment to injury can be a really big barrier to improving daily functioning, which is the outcome that we're looking for after cog rehab. And as we all know, changes to mood, increased anxiety can have a big impact on cognition. So even without new injuries, new diagnoses of conditions that can cause cognitive impairment can also pose challenges and also require a period of adjustment as well. So think MS as an example. So as part of the neuropsychological approach, we want to target these issues in treatment because it's incredibly important to ensure overall wellness and quality of life. So I'm definitely not recommending that you're doing psychotherapy in tandem while doing cognitive rehabilitation. That's too much. That's not going to work. But skills training for some of the most common emotional and behavioral problems following any CNS injury, so depression, anxiety, irritability, anger, all of those things are going to help improve daily functioning and improve recovery trajectories. And it's also going to limit any interruptions to rehab that may happen due to low mood and due to anxiety. Okay, so I've been mentioning ecological validity as we've gone through some of the slides. And most of you are likely familiar with the term when it comes to assessment. Much of the same is true for neuropsychological rehabilitation. So ecologically valid rehabilitation programs ensure that treatment is applicable to everyday life. So teaching someone to become more proficient at list learning is not necessarily going to be as helpful as teaching them how to build and compensate for prospective memory ability if they can't remember appointments or can't remember to take their medications. So what we do to achieve ecologically valid rehabilitation is use any manualized treatment that you'd like, but then include the focus of ecological rehabilitation in your initial session. And you can go about this with your clinical interviewing skills, and you can use those to assess for the patient's current level of everyday functioning. So I always like to ask patients, like, tell me what a day in your life looks like. And then use that to help really inform their goal setting. So the first session is a time to introduce what rehab is, the focus, that ecological focus, also introduce what rehab isn't, and then to set those personalized goals. And so with setting goals, we really want to encourage those personal goals and encourage them to have a functional component, like, okay, I want to cook dinner 3 times a week. And we really want to start where someone is at and then move them slowly and steadily in the direction of their goal. So, for example, if someone's not cooking and they want to get back to cooking, we might start them with assisting with meal prep a few times a week in the kitchen, then to making simple snacks without heat, then to making a simple meal with heat, like scrambled eggs, and then after that, taking on bigger dinners. We never want to start with Thanksgiving dinner. We really want to scaffold those abilities in our goals. One thing that's important is making sure that when you're working on these independent activities of daily living, that you do have a family member or caregiver, someone who could be there to provide observation, to provide monitoring, and from that metacognitive perspective, be there to provide feedback following the task so that people can create or rather generate more awareness about their ability levels. So another really cool thing to do when you're trying to employ more ecologically valid rehabilitation is use technology. Invite the use of more modern uses of external support. So reminders, alarms, alarmed pillboxes, Hey Google, Alexa, Siri. Hope I didn't turn on anyone's technology there. And if someone has difficulty using technology, adopt errorless learning strategies to improve that ability. And if newer tech is too challenging for a patient, try to use simpler tech options, because not using tech to support external strategies can be really difficult for patients because of the natural growth and reliance of technology that we all have in our everyday lives, in 2023. So one note here is that some of the older manuals for COG rehab, they're great manuals, but they may have older external strategies, like note-taking. Post-its, I use Post-its. It's not a bad strategy, but you may get less buy-in from someone who's younger. So making sure we're including updated technology is always helpful. And then when working with patients, we want to incorporate real world scenarios into treatment, such as remembering passwords. And when working in outpatient settings, we want to encourage people to practice the compensatory strategies that we've come up with in session in their homes, like using memory strategies while grocery shopping. In inpatient settings, setting up a transfer of skills is always a bit simpler because many acute rehab settings have like model homes, kitchens, simulated community engagement activities. And then in progressive care units, if you're working orphan ICU unit and you have medically stable patients and you want to start rehab, it's also a little bit easier there too, because you can have them practice simple skills like communicating with their medical team, using some type of note-taking or voice memos to recall important information, and you can be there and be applying oversight while they're trying to practice those skills. Another way to ensure transfer of skills is to include family, include caregivers at certain points in treatment so that they're aware that these strategies have been taught, and then be aware of what we're looking for, and to create opportunities to practice those strategies and provide feedback when someone returns home. And then one last thing I'll say about ecological validity is toward the end of treatment, you always want to try to identify any future barriers that you may suspect could come up and consider a plan of action to employ in the event that that does come up. For example, let's say you're working with someone post-injury, they're doing really well, they're wrapping up treatment with you, but they plan to go back to college in a couple of months' time at the start of the new semester. You might troubleshoot how adjustment to injury, increased demands on the person could come up and what to do about those things. So wrapping up treatment, especially ecologically valid treatment, does require some booster sessions. And just a reminder that ecologically valid rehab is rehab that grows with someone. So after neurological injury like TBI or stroke, we're going to have natural recovery. Rehab is going to be added into that. It's going to work great to help improve patients' abilities. But over time, those new challenges in everyday life will impact their functioning and will need to be addressed so they can continue that upward trajectory of being independent in their everyday lives. Okay, so I wanted to show you the current practice standards. If you deliver cognitive rehabilitation, you've probably seen this. This is a review from Cicerone et al. In 2019, a large review, and he's done one before. This is the most updated one. And this one talks about really general standards that should be used when practicing cognitive rehabilitation, providing cognitive rehabilitation. Some of the things the review included was making sure that you individualize your treatment to reflect both patient strengths and then areas for improvement, that the treatment plans that you create, those goals that are created with patients, that they're flexible. If someone needs to add a goal or delete a goal because it's no longer relevant, that you do that and you check in with goals as your treatment moves forward. And also that you use cognitive and self-report measures to make sure you're tracking progress as treatment progresses. A recommendation, use ecologically valid cognitive testing whenever you can. So things like the Rivermead, the Pillbox test, to ensure that you're measuring independent functioning and not just objective cognition alone. And then you also want to consider multimodal interventions. So kind of, again, with rehab, all these things sound like they are. So using various modes in your delivery of cognitive rehabilitation. So maybe cognitive exercises that include art, music, pictures, written excerpts, pencil and paper-based activities, computer tasks, real-world settings where you're using technology together, practicing communication skills, and so on. Cicerone also highlighted some limitations of cognitive rehabilitation, hence the need for ecological validity, and recommended that you use ecologically valid techniques, as we just discussed. And then also making sure that when you're engaging in treatment with someone, like I said before, you always want to share what cog rehab is at that first appointment. You also want to share what it's not. So you always want to say, hey, cognitive rehabilitation is great at helping you improve your functional abilities. And then never promise any kind of return to baseline functioning or cognition. That's not what cog rehab is, and it's not what cog rehab does well. Cog rehab does a lot of things well, but not that. Okay, so I wanted to show you guys some of the more detailed practice standards from the Cicerone study specific to cognitive domains. So if you look at that first one, you'll see that for attention, they're recommending incorporating both direct attention training strategies and metacognitive strategies, and doing those in a way that will promote generalization to daily functioning. And then there are two practice standards for memory. The first one is targeting perspective memory, using internal and external memory strategies. So things like internal strategies like imagery, association, external like notebooks or any electronic technologies like we discussed. And then also they speak specifically about everyday memory. So things like remembering to take medications, remembering appointments, remembering to eat, remembering hygiene, those types of things. Internal and external strategies, again, recommended. And then last but not least, I'm sorry, I have like 3 screens, so I can barely see it, but executive functioning, using metacognitive strategies, using skills to target emotional self-regulation and problem-solving therapy, and then really how to apply those things to everyday life is definitely a theme. Okay, looking at time, we're close to time, so I'll go briefly over this. one of my favorite books, the Cognitive Rehabilitation textbook from McKay, Moore, and Solberg, give a list of really great rating scales. I borrowed some of those here on your screen and added some of my own. Like Cicerone recommended, it is a good idea not only to use cognitive testing and ecologically valid testing whenever possible, but also rating scales throughout your treatment to help you notice and track improvements, but also any unexpected decline, and to help guide you if you need to make any changes to those personalized goals that were set at the start of treatment. Okay, so some trends in the research. So regardless of the many new developments in cognitive rehabilitation programs and applications, good data on the effectiveness of cognitive rehabilitation is unfortunately still growing. And that's because the history in cog rehab includes a lot of really inconsistent research. Things like heterogeneity of participants and the types of interventions, the types of rehab, just the size of the studies, all of those different things made the research not great. Lately, there are a couple of different things we see trending in the research. Ecological validity is absolutely one. Slowing down decline following MCI is one. And although you'll see, although you'll see a lot of things focused on TBI and stroke, you are seeing more stuff come out for MS and Parkinson's and so on. So I want to kind of go through some of these here. The biggest thing that you see is technological advancements. So one of the things that are really trending in the research right now is using VR to help support cognitive retraining. Again, not just restorative models, but compensatory models too, where you're taught how to compensate for something and then put in a VR setting where you're able to sort of employ those compensatory strategies. So the first article in the upper right of your screen was conducted by analyzing 21 studies, and meta-analyses found that compared with the control group, VR rehab training actually increased scores on a bunch of global cognitive screeners like the MMSE and the MoCA, but also on the Rivermead, and showed independence in ADLs following functional assessment for people who had cognitive impairment after stroke. I'll also talk briefly about the bottom right of your screen. That's a study that included 17 RCTs and had moderate evidence that VR cognitive training improved, again, global cognitive functioning on the MoCA, as well as TRAILS A, but in comparison, did not show any improvements in delayed memory or immediate memory, didn't help with attention, and did not necessarily help with activities of daily living either. And for that study, the results were only present in the short term. The bottom left, you'll see an analysis that included 5 studies from 2012 to 2022. Again, VR-based cognitive training. And this was actually an interesting study because it showed effects that were pretty significant for ADLs and IADLs in both MCI and AD patients, which is good to hear and difficult to achieve. And I want to just draw your attention to the top left of your screen. Peer support, I'll say a quick word about this. This is a growing trend in the research, and appreciation for peer support after neurological injury is growing. This was a study that showed that there were a few improved outcomes, health, confidence, self-management after having peer support during traditional rehabilitation programs. So that's definitely something that we're starting to see more about and hear more about, is including peer support when we do rehab. So here are, as promised, those recommended resources. Some of the manuals that I like, the EON MEM and EON Exec manuals. CogSmart I love. The American Congress of Rehabilitation Medicine has a cognitive rehabilitation manual that I like. And then the workbooks that have some really nice exercises are listed up there. And as mentioned before, the McKay textbook, they have 2, the cognitive rehabilitation textbook, and then optimizing cognitive rehabilitation as well. And then if you are looking at a good comprehensive study, the Cochrane 2019 meta-analyses by Cicerone is the first place that I would recommend starting. So if you are not doing COG rehab, but referring to COG rehab, here are some things to consider. The first is making sure that you're not only sending over a patient with targets, so cognitive domains that need improving, but also anchors, strengths in that objective data that we can use to help build compensatory strategies on. If you have someone who you're seeing that has a progressive neurodegenerative disorder, they are not a good fit for cognitive rehabilitation. As you're rehabbing, the progression is happening at the same time and canceling everything out. So COG rehab works best when people are not experiencing a progressive condition. If you have someone with significant aphasia or global aphasia, they might need speech therapy or assistive communicative devices before they can engage in something like neuropsychological rehabilitation. If you have someone who's got a lot of secondary factors going on, sleep problems, pain, mood, that your rehabilitation provider knows, so they can include that in their treatment plan. And then make sure you're sending over patients who are at least a little bit motivated, because if you're sending someone to a provider who works on the outpatient side, they're seeing someone once, maybe twice a week. So there's a lot of at-home practice that needs to happen, which does require a fair amount of motivation. So I'm looking at time and I want to make sure that I leave time for questions. So I am going to quickly go through this case presentation. This is a pretty typical case presentation. We get a lot of post-TBI, post-stroke patients that we see. A lot of people that we see are people who have pretty big goals about things like returning to the community. So trying to get back to work, trying to get back to driving, and sometimes even just trying to get back to communicating better with their families after injury. So this person had a moderate TBI due to a fall, 46-year-old white male, and on cognitive testing had problems with attention, executive functioning, and a very dysexecutive pattern of memory impairment. He had some good strengths. What he did in code, he was able to retain, and his simple attention was okay too. Psychologically, he was doing fine, again, really motivated to get back to work. And his big goals for rehab were improving his attention ability and getting better at problem solving. So we worked with him for 12 weeks. We did graduated independence in steps like getting back to managing his medications. After doing that, getting back to managing his finances, and then eventually returning to work. And after this was about 7 months after injury. At about 12 months after injury, he was retested, and he actually did well quantitatively too on cognitive testing. He had improved encoding and improved sustained attention, and then luckily was doing well at work as well. I say luckily because sometimes some of those things don't always translate when people have higher order jobs, and he had a higher order job, but he was able to do well with accommodations. So I'm sorry that I wasn't able to go through more detail about the case presentation, but I will stop here and take any questions that you guys have. Thank you so much for your attention.
Thank you so much, Dr. Fullen. That was an incredible presentation. It was so detailed. You hit all the important points and more. And unsurprisingly, we have a ton of great questions for you. This is something that I was actually thinking about as well. So the question here is if you can speak to interdisciplinary settings and how roles of different providers, how they are established and maintained. So, you know, what is speech doing? What is OT doing versus what's neuropsych doing? Because it seems like at times those roles can be muddled a little bit. So just wondering how you practice and what that can look like and how to establish and maintain those roles.
Yeah, that's a great question. I think that I've definitely been in settings where there was a little bit of a turf war, especially about who does cognitive testing, who does rehab. In many settings, speech therapy is doing a lot of basic cognitive evaluation, sometimes even OT as well. And speech therapy is also sometimes doing the bulk of the cognitive rehabilitation. My way to kind of address this is if you're sort of entering into a team or you start a new job somewhere or you start a new program somewhere, is to really sort of all get together, figure out what the process is, what the process is as you sort of enter into that setting, and then work to support one another. So, if 3 different groups of people are all doing rehab and they can all do even the same rehab, honestly, from a brain perspective, that's not going to hurt anybody. But I also think at the same time, while we can support one another, it's nice to lean into our areas of expertise. So while speech might go in and do a baseline cognitive evaluation, neuropsych can go in and do more nuanced domain-specific testing. We can also work with patients and their families, not just on cognitive domains, but some of the psychological implications of injuries and how to transfer some of the skills that maybe they're working with OT and PT, how families can transfer those. We can do a lot of really good psycho ed into the home. So I guess to kind of summarize, we can all work together to do some of the awesome things where there's overlap. And then we also all need to lean into our niches of expertise because there is absolutely a place for everyone.
That's great. I think you highlighted too an important part of it, of being on the team, is that communication. So really having a good idea of what everyone's doing, what everyone feels comfortable with doing, what that scope looks like, because we all do things differently, but kind of similarly at times. So having a good understanding of where everyone's at. Similarly, some of the parts and pieces that you're describing, obviously we play a big role in providing psychoeducation, neuropsych related brain health and education. But then there's also pediatric rehabilitation psychology, our colleagues too. And you had mentioned that there are times where, maybe take a break from cog rehab and do some psychological intervention. And I was curious, are you providing that intervention, or do you work with your pediatric? I'm sorry, I'm saying pediatric because I'm a pediatric person. Psychologist colleagues for that piece, or is that you providing that?
So no. So if I'm working with someone and they have, let's say, just some subtle difficulties with, let's say, anxiety, and we're also doing cog rehab, we can absolutely address some of that anxiety with like simple skills. But if someone really needs to go to psychotherapy to like work on a full-fledged anxiety disorder, PTSD, major depression, then I'm referring out for them to see one of the psychotherapists or social workers who provide psychotherapy here.
Okay, that makes sense. Let's see. Some other questions. Oh, right here. There's a question/comment and wanting to get your thoughts on the purpose of compensatory strategies, and if you think that might be the development of new pathways in the brain.
Great question. I'll start with the latter. So there's still a lot that we're learning about how the brain heals after something like traumatic brain injury. In fact, there is so much evidence that's showing that there is so much chronicity in something like TBI. For example, changes to the blood-brain barrier, neuroinflammation, those things continue months and even years after the initial injury. At the same time that those problems are occurring, there are also processes in the brain that are designed to heal and do other things. So we know neuroplasticity is a thing, but how and to what degree it works, we don't know enough about. When it comes to rehabilitation, I absolutely think that there can be some new pathways. I typically think it's related more to sort of a blend of any existing solid memory ability versus potentially, if there's some memory difficulty, leaning on things like procedural learning and what that looks like in the brain to be able to have something like compensatory strategies that can be almost integrated into the way that we kind of think and go through things. The biggest thing with cognitive impairment is that there's so many things that the brain does for us automatically. After an injury or cognitive decline, we have these things that the brain is not doing automatically because there's impairment in this ability, right? So with compensatory rehabilitation, what's happening is you're almost, instead of having this natural thing happen, you're providing an opportunity for someone to automatically do something. So sure, it could be related to some neuroplasticity, but it's also potentially related just to leaning on other parts of the brain to be able to employ that set of not automatic abilities, because the automatic abilities are lost.
Yeah, that's really, I appreciate the nuance in the answer, because like you said, there's a lot that we're still learning. Healing takes a lot of time. And I know it's 4:02 and you've graciously offered a little bit more of your time. So maybe 2 more questions, because
Sure.
I'm so excited about this. Rightly so. So the next question is on ecological validity on outcomes. On average, for how long are the benefits of rehab seen? And how much generalizability to daily situations are you seeing? Are there any studies that look at effects X years or months after intervention?
Yes, great question. There are 1 or 2 studies, and I can't think of the author name now, but if I didn't have all these slides on my screens, I could tell you. I could try to pass it along. I don't know if there's a way to pass it along, but there are studies that are showing that rehabilitation efforts, not just cognitive, but from all rehab teams, result in functional gains and independence in daily living activities and independent daily living activities 10 to 15 years post-traumatic brain injury specifically. I can't speak to stroke and other neurological insults, but with TBI, there is a lot of focus on TBIs. We see a lot of rehab research in that population, but up to 15 years is where we're at right now, where we're seeing that ecologically valid approach having standing positive effects.
That's incredible.
Yeah.
It's so exciting to hear. One last question, it is related to trainees, so I want to squeeze this in real quick, is what can trainees, specifically PhD students, do to gain more training experiences in cognitive rehabilitation, especially if there aren't opportunities at their institution? Or what training experiences do you suggest to prepare for a career in cog rehab? So maybe in addition to those books and website resources, what clinical experiences might be helpful for them to look into?
So often at INS or NAN, you'll see they have workshops where there's a lot of how to do cognitive rehabilitation and other types of intervention, be it targeting adjustment to injury, providing psychoeducation, a good feedback session, all of those types of things, leaning into not just our assessment skills, but our intervention skills. So that's something that I would prioritize. The other thing would be to, unfortunately, this is maybe not a great answer, but try to find those opportunities to actually get to practice cognitive rehabilitation. If you're reading all the resources and stuff, at a certain point, you're going to have to get the opportunity to have supervised experience. So trying to find sites that have cognitive rehabilitation options for practica, internship, and fellowship is going to be important if it's something that you really want to do. And one last thought, I rely super heavily on my my therapy teams in the inpatient setting that I work. So if you can hang out with PT, OT, speech, especially speech and OT, because there is some overlap in the way that they provide rehabilitation, and maybe do some shadowing, that would be another nice way to sort of boost your training until you get the opportunity to have supervised, practice.
That sounds great. Well, thank you so much, Dr. Fullen. We really appreciated this and learned so much from you. And yeah, thank you again for being a part of this.
Thank you so much for the invitation. Take care, everybody.